So good morning all of you, and thanks for attending this session on low vision. So I'll be talking to you on pediatric low vision assessment. So before you know about the pediatric low vision, you need to know something about the developmental milestones in children, because unless you know what to expect, you may not actually recognize that this child has low vision. So can I have a pointer, please? So if you see around 3 months, the child should look at the mother's face. Around 6 months, the child should try to touch objects, and around 9 months, if you see here, the child starts looking at the mirror and smiling and picks objects, and by around 1 year, it can imitate others' actions, and by 2 years, can start observing pictures, and by 36 months draws pictures on the floor. So by 3 months, if the child doesn't look and fixate on the mother's face and the social smile is not there, then there is a concern. There is a concern on part of the parents, and then they think and bring the child to the eye care provider. Especially if this is a sibling, there is an older sibling who has had milestones. These milestones have been achieved earlier, and then the next child, there is some problem, then the parents are able to pick up these issues earlier on. So you can just have a look at these two children. You can see that the light is being shown. The second child is able to fix light, but is not able to see any objects. The first child is not able to see light also that well, really not able to fixate on any objects. So both of them had a history of poor vision from birth, and they were born of second degree consanguineous marriage with a normal anterior segment, retinoscopy showing hyperopic shadows and mild changes in the fundus cavity. So there's very low vision here, very close. I mean, if there is some lighted objects, the child is able to see well, but otherwise the vision is only within 1 meter distance. So what do you do when you are faced with such children in your OPD? Anybody doing pediatric practice here? So any guesses on what the condition may be? Poor vision from birth and normal findings plus retinoscopy, mild fundal changes. So what would be your next approach? So we went ahead and did an electroretinograph. As you can see here, it's a flat ERG both on scotopic and the photopic responses. So this is the ERG has to be done under anesthesia in small children, and you can see the procedure here. It is being done in a dark room, and the readings are being obtained. So this is both the children are suffering from a condition called as Leber's congenital amaurosis. So this is one cause of extremely low vision in children. And the prognosis is not very good. Most of them are have to study in a special school with the Braille methods, and they don't have that much of useful vision. So how do you classify low vision in children? You can see that there are one class of children who have abnormal findings, and you can see them. Therefore, this child is having microphthalmic eyeball with a large fundal coloboma. And there could be children who are having ROP, and you do the imaging and you see traction detachment. This child, you can see the white reflex here, and actually is having a congenital cataract. So there could be an abnormal ocular exam. So that is one category of patients. Or everything is normal, but there are no ocular findings or retinal, but there is an abnormal electroretinogram. And the third is there's a normal ocular exam but abnormal findings. So this is how you can classify them. So when you don't see any apparent visual response, then what would be the next approach? So in such children, the next approach would be to see if there is nystagmus or not. So if there is nystagmus, then you go ahead and examine the anterior segment. You see if there is any problem in the anterior segment with respect to cornea, lens, retina, or optic nerve. If there is no other abnormalities and no nystagmus, then you see if there is a spontaneous vestibulo-ocular reflex. If it is there, then it could be in the category of cortical visual impairment or delayed visual maturation. But if the vestibulo-ocular reflex itself is abnormal, that means that the doll's movement is it's not there. So it could indicate some muscle problem like congenital oculomotor apraxia. That's why the child is not able to fix and move on the target, or saccadic palsies. And good refraction is extremely important, because it could just be a high hyperopia or a high myopia and the child is not seeing. Once you give the refractive correction, the child will be able to see well. So you examine the external eye. If in the external eye itself, sometimes children with low vision could have some abnormalities like microphthalmia, aniridia, albinism, cataract. On fundus you could pick up glaucoma, or it could be having a megalocornea with half striae and such. So if these are there, then your diagnosis is very easy. If the external eye is normal, and as I said in my previous slide, you go ahead and see if there is nystagmus or not. And if the fundus, again you classify as normal or abnormal fundus. And if the fundus is normal, you have to do some electroretinographic studies. Again, if ERG is normal, it could be, then the diagnosis could be either delayed visual maturation. So that category is what is delayed visual maturation? It is everything is normal, only that the child is not getting the visual responses earlier on. So the prognosis is very good. You just wait for some more time. The child is not fixing at 3 months, may start fixing and following objects at 6 months. So that is delayed visual maturation. Cortical visual impairment is where there is some other abnormalities in the cerebral cortex, like a child has some history of periventricular asphyxia, leukomalacia, other things, where the eye exam is normal but the child is not able to see because of a problem in the brain. Then saccadic palsies. If ERG is abnormal, you can get the diagnosis based upon the ERG, like Leber's amaurosis or other retinal dystrophies. And when the fundus again is abnormal, it is easy to diagnose based on the what you see in the fundus. Sometimes it could be because of optic nerve pathologies like optic nerve dysfunctions like hypoplasia, optic atrophy also can cause low vision. There could be vitreous anomalies. So a detailed exam is very important. So have a look at this patient. These two children have similar diagnosis. So this is visual inattention from birth, full-term normal delivery, and had a stormy neonatal period with respiratory distress and was in an NICU for 2 weeks. You can see the child is not really interested in seeing any objects at all or even light. The other child had hydrocephalus and seizure disorders. So here the ocular exam is everything is normal, but the child is not able to see anything. So what are these? So what do you do then? You can do an investigation called a VEP, which again done under anesthesia in very small children. So what is the use of seeing a VEP? There are two types of VEP. One is flash VEP and there is a pattern VEP. So you try to see if they are stimulating the optic nerve and whether you are getting any response. So there are three components to the VEP. There is a latency, there is the amplitude. So we see whether there is any prolonged latency or reduced amplitude. So these two children are suffering from the condition called a cerebral visual impairment. So what is this? This is coming up in a big way now. Many children we are underdiagnosed earlier and now we are diagnosing this more and more. So this is bilateral vision loss because of cerebral cause and with a normal ocular exam, and because of advanced neonatal care we are seeing more incidents of cerebral visual impairment. So the causes for this include any problem in the neonatal period like hypoxic ischemic encephalopathy, child didn't cry immediately after birth is a warning bell. Any cause of birth asphyxia, hemorrhages, preterm children with periventricular leukomalacias, structural anomalies, hydrocephalus, some meningitis, trauma, all these could be the causes for cortical or cerebral visual impairment. So what are the characteristics? You have a look at this child. The child is, we are showing the smile here. Your child can, just to see whether there is a response, and this is a test of contrast sensitivity. The hiding head test, and then again we are using the LIA paddles to see if there is any grating visual acuity. So the children with cerebral visual impairment have a lot of characteristics. So what are they? There is a need for movement to elicit a response. A child may not look at static objects, but when there is movement there will be a response. There is a visual latency. The child will not see as soon as you are showing the object, but there is a latency in the response. And there are field preferences. Some child prefer to look at up or up gaze or down or right or left. So there is a specific field preference. So you need to look at that. Difficulty with complexity. Simple objects the child will be able to see, but complex environments they perform very badly. Light gazing. There a child constantly looks at light. Atypical visual reflexes, there is no visually guided reach. You show the object, the child will turn and then grab the object. So that is absence of visually guided reach, lack of blink to threat, and difficulty with visual novelty. I think I need to take another 5 minutes, sir, if that is okay. So greater the number of characteristics, the more severe is the cortical visual impairment. So based on that, you can grade the CVI into several ranges based upon the function. So CVI range of 1 to 2, there is minimal visual response. That is like the very severe aspect. 3 to 4 is more consistent visual response. So these two fall in phase 1. While 5 to 6 and 7 to 8 uses vision for functional tasks, demonstrate visual curiosity. So these two come into roughly into phase 2, and then 9 to 10 is the one where it is good, where spontaneously uses vision for most functional tasks, that is phase 3. So after grading it, we give the interventions for the child depending upon which phase of CVI they are in. So the history taking for any child with cortical visual impairment is very complex. You need to spend a lot of time with the children, ask a lot of questions on the parental, see there are a lot of questions like how the child looks at the mother's face, is there any eye poking, social smile, and etc. And then about the antenatal history, birth history, NICU admissions, and coming to examination, again it's like quite the detailed, very detailed examination which takes a lot of time, as you can see here. And in phase 1 category, what are the interventions that we give? The environment is very controlled with minimal distractions. You start with single colored objects and with little or no sound, and watch for fatigue. So this is how you do the visual therapy, vision therapy for such children who are in phase 1. And coming to phase 2, you started stimulating with more than one color, document a decrease in visual latency. You can use light boxes. What are light boxes? These are boxes kept in the dark environment with objects on it, and then that helps in visually guided reach, and newer objects can be introduced slowly. So this is called as a light box, where the child is, you can stimulate with different colored lights and objects hanging, and that seems to elicit some kind of interest from the child. And coming to phase 3, again you familiarize the child with environment. Mobility training is started now. You can start with simple picture books, and once a child comes into the phase 3, which is a resolution phase, early, mid and late resolutions again. So early resolution, first thing which will go away is the light gazing and the atypical light reflex. In the mid resolution, the color preference, that is usually the child may prefer red or yellow, those things go away. Visual latency, need for movement, all these go away. Late resolution, the visual field preference goes away, and if the therapy is successful, the child starts seeing well. So there is a response to concrete and abstract visual materials. And so what are the clinical assessments include a lot of questions, like any child with low vision, you need to answer these questions. Whether the child is having low vision, or why does the child have low vision, what is the prognosis, what is the functional vision. So this functional vision question you need to answer always, as to how best the child is able to function in the environment, and whether this is a progressive condition. So functional vision again measures how well the child uses the vision in a particular, to do some particular task. And evaluation, it is a repetition, so you need to take a detailed history and examination, including visual behavior, field testing, color vision, contrast, motility, slit lamp fundus, all these form a part of your low vision evaluation. Toys, again for visually impaired children, need to incorporate different senses together, like touch, feel, sound, everything, for them to get more interested. Enhancing residual vision is by environmental modifications and devices, which can be classified broadly as optical, non-optical and electronic devices. And basically for children we mainly use magnifiers, which are handheld variety, or you can use electronic handheld magnifiers. And for the distance for children, we use telescopes, which may help them in their school work. These telescopes can be monocular or binocular. Whatever devices we prescribe, we need to communicate to the teachers regarding the classroom seating, avoiding glare, use of dark pencils, bold line notebooks, bold letters, and to be compassionate to the children. And we did a USAID project in Coimbatore, because most of these children don't come to the hospital, and we thought that outreach activity is very important. So this was from 2014 December to 2016. December to 2015 to 2017, so 2 years period, and to enable early identification of the children in the community and refer to a base hospital, and also we wanted to subsidize the cost of low vision devices. So we achieved these targets by the teacher training, by training the Sarvasik Shabyan teachers in all the local area, and organized a lot of camps, and the teachers were very cooperative, and the children actually started using the devices in school and improve their performance. And with the 2-year period, we could screen almost 8 lakh children and identified around 1577 children and prescribed the glasses and the devices. And so that's a way to go forward about community low vision care also.